Okay, here we go with the antidepressant module. Like the previous modules, for completeness, the slides do have the DSM-5 criteria included. Well, we're going to skip over those because you'll cover those in other courses. I just want you to have them for completeness. So we're skipping over screening, assessment. We're going to go um, straight to treatment. So here we go. Jumping into where we're going to start talking about medications. So medications that can worsen depression. So here's a list of some of them. You can see that some of them are fairly popular medications, are fairly common. Anticonvulsants have a black box warning as a class for increased depression or suicidal thoughts. Benzos, beta blockers, calcium channel blockers, interferon, isotretinoin or Accutane, and levonorgestrone implants, opioids, and varenicline, which is also Chantix for smoking cessation. So there's some popular or some very common medications in there that can worsen. So if somebody has, uh, somewhat stable or they've worsening symptoms, you want to look and see first of all, is it a medication that might be worsening their symptoms. So if it's not a medication worsening it, and we can't discontinue that medication or change it to something else, we are going to have to treat the depression. So options are medication, psychotherapy, combination therapy of psychotherapy and medication, and electroconvulsive therapy and light therapy. In general, psychotherapy is the most effective treatment option for depression, and along with combination therapy. Most patients are going to want to choose medication because that's an easier option. It's usually less expensive. There's less trouble getting insurance to cover it, and I just have to go get the prescription filled once a month or once every 90 days and take the medication. But the psychotherapy helps with coping skills. As long as the skills are maintained, it has a longer duration of treatment. It actually addresses, the basis of the problem. So it's a psychotherapy. You really want to recommend psychotherapy, cognitive behavioral therapy or counseling therapy, something along those lines, used in combination with medication. You want to use those. The electroconvulsive therapy, usually used for treatment-resistant patients, and so is the light therapy. Usually, if combination therapy is not effective. So treatment principles, the terms you're going to hear is response, which is a reduction of symptoms by 50%. Remission is a reduction of symptoms by 100% or a return back to baseline. And recurrence is a return of symptoms after the 4 to 9 month continuation phase of treatment. So if it's before that 4 to 9 month continuation phase, it's going to be seen as the same episode. So it'll be the same occurrence, not a recurrence of depression. In general, all current antidepressants are equally effective. That is a population level efficacy. It does not mean, like we've talked about in the intensive and some of the modules before, it doesn't mean that for each person they're all equally effective. But if you were to give it to 100 people, the same percentage of people are going to have response, remission, and no effect. And this was seen in the STAR-D trial, which I highly recommend going and at least finding a synopsis of. It was comparing antidepressants in patients, and it's a really good kind of overview of the efficacy of antidepressants. So an antidepressant will lead to response in 2/3 of patients in general. About 1/3 of those patients will gain remission from an antidepressant. So what you're seeing is like a third, a third, and a third. So a third will get remission, so completely back to baseline on one antidepressant, on the first one. And the next third will have some kind of response. So symptoms will Some symptoms will resolve, others will not, or they'll lessen. And then 1/3 of the patients will not have an effect on that first one. And so then you're going to change the medication again, or maybe try 2 antidepressants, to help those patients. And 1/3 of patients will never reach full remission on antidepressants. So you're going to have some kind of other therapy, electroconvulsive therapy, psychotherapy, something along those lines that will help out. Symptoms that may persist after treatment, the ones you're going to see the most are the insomnia and fatigue, the somatic complaints, so the appetite and those kinds of things, and then lack of interest and motivation. So they're not suicidal, they don't have the sad thoughts, they just don't have the interest of going out and doing things that used to motivate them. Antidepressant response based on age. So for patients who are under 18 years old, there has been seen an increase in suicidality with less proven benefit versus other age groups. The risk versus benefit, because a 1% increase in antidepressant use equaled a 23% decrease. Well, so it's a risk versus benefit, sorry, because a 1% increase in antidepressant use equaled a 23% decrease in adolescent suicides per 100,000. So what it's saying is there may be, for teenagers, under 18, and even up to 25-year-olds, you can see in this bullet right here, there may be an increase in suicidality compared to older populations on antidepressants, but that's still overall much less than suicidality for untreated depression. So the risk versus benefit probably tipped very heavily to the benefit side versus the risk. But if you do have a patient who's in their mid-20s or younger, you want to make sure they know that if they have worsening thoughts, to let you know that it could be the medication. So you can always change the medication or go with a different treatment method. And that way, to let them know that is a possibility. It doesn't mean that it's going to happen, but it is a possibility you want to talk to the patient about, because you don't want them to think that that their depression is worsening. So symptom time of response for antidepressants. So we have a general rule that antidepressants take up to 8 weeks to become effective. But it's not that we just keep going, we don't feel anything, and at the end of week 8, oh boom, now our symptoms are resolved. It's a gradual relief of depressive symptoms. So in the first few days, it's going to be, you're going to have you may have an increase in agitation or anxiety, which is common, because it's kind of like because we're at a new normal, we're coming out of that depressed response. We may have an increase in agitation or anxiety, but we're also going to have an improvement in insomnia or sleep. So if the patient is not sleeping or has excessive sleep, and the appetite's going to improve. So there's going to be some benefit in those first few days. They do have an increased agitation and anxiety, which may be a good option for patients who need something for PRN for those. A benzo, Atarax, Vistaril, Benadryl, something like that may help out with that. You may want to do that for like a week or 2 weeks, and then have that stop, because you don't want them to become tolerant and dependent on it. In 1 to 3 weeks, you're going to see an increase in activity and in sex drive. You're going to see an improvement in self-care habits. Concentration and memory will normalize, and sleeping and eating patterns will continue to normalize. And then from that 2 to 4 weeks up to 8 weeks, that's where you're going to start to see the relief of the depressive mood. They're going to start to do activities that they enjoy, or experiencing pleasure again. They'll feel less hopeless, and the thoughts of suicide will subside. So it is a gradual continuum of symptom relief, not just you take it like a blood pressure medication. I take it, my blood pressure drops, and then I just continue taking it to maintain that low blood pressure. It is a gradual relief of those symptoms. So how do you know which antidepressant to choose? Because we've said earlier that they're all equally effective. We don't have our guidelines don't prefer one over the other. Diabetes, it's real easy. We prefer metformin unless their A1C is too high. Then we need insulin. That's the gold standard to start with, and then you can add on based on other factors. Well, when you have classes out of the ones we're going to talk about in a little bit, SSRIs, SNRIs, Wellbutrin, and mirtazapine or Remeron, that are all equally effective and all equally tolerable, how do you decide which ones to start with without just simply throwing a dart at a dartboard and guessing? Some important factors are going to be patient preference. Have they heard something about one or the others, or they had a friend who took it and they had a side effect and they want to avoid it? We have to take that into account, because if they don't want to take the medication, they're not going to take the medication. So then they're not going to get any benefit. Is this a recurrent episode and they've had prior response? What's the safety profile of it? If we have a patient who has had a couple suicide attempts before, and they've said that they have a plan this time also, we are going to have to pick a very safe antidepressant like an SSRI or an SNRI, which is very safe in overdose. So even if they get a month's worth of the prescription and take the entire bottle, it doesn't have the potential to kill them. Tolerability and adverse effects. The side effects of these medications are not the same across the board. So which side effects are we trying to avoid, or maybe which side effects are we trying to use to treat the symptoms of their depression? So we'll talk about that in a minute when we talk about the specific antidepressants. Do they have any comorbid disorders? Because some antidepressants you can't take if they have a seizure disorder. Or they're also used to treat fibromyalgia. So if they have fibromyalgia, don't add on another medication. Let's kill two birds with one stone. Potential drug interactions, pharmacokinetic parameters, and something that I'm sure you're probably going to get tired of me saying this semester is cost. A lot of them are cheap generic options, and then there's a few that are name brand only, which a lot of insurance companies are not going to cover. Or they're going to cover at a high copay, so they're not going to pay $90 or $150 for the medication when they can just pay, maybe a $4 option is just as effective. So we'll talk about those options as we go through each one. The tolerability, the drug interactions, as we talk about individual agents. But in general, our first-line pharmacotherapy are SSRIs, or selective serotonin reuptake inhibitors, SNRIs, serotonin norepinephrine reuptake inhibitors, bupropion, or Wellbutrin, and mirtazapine, or Remeron. If symptoms persist after 4 to 8 weeks, then you would switch or you would augment that medication. Usually 4 weeks is a good that third or fourth week is a good time to assess whether they're getting some effect from the medication, because usually by then, if you haven't had some benefit, you're not going to automatically have this massive benefit at week 8. You should at least seen something where they may say, I'm sleeping a little better, I'm eating, my appetites come back, or I'm not excessively eating all the time, things like that. They may not be back to baseline, but you should see some benefit. With less than 50% improvement after 8 weeks, switching treatment is recommended. And if 50% of improvement has occurred at 4 weeks, continue to go to an optimal dose. So you may want to max out that antidepressant. Treatment phases, you're going to have an acute phase, weeks 6 to 10, or for 6 to 10 weeks, continuation, which is 4 to 9, and then maintenance. So, your acute phase is a patient's acutely suicidal, or you're trying to find the right treatment. Continuation, you're going to continue the treatment, and then maintenance, you're maintaining, and that may be a time when you're assessing. Okay, do we want to pull back on the treatment? Do we want to start to discontinue the antidepressant and continue the psychotherapy? What's a more long-term benefit? And if the patient, if they've had several episodes, they may be on the antidepressant long term. If this is a first episode and things in their life have turned around, and the precipitating event or events have resolved, then maybe we can come off that antidepressant and just continue therapy. Response to treatment is, obviously 50% reduction in symptoms. Remission is a lack of symptoms for 2 months. And the predictors of remission are patients who are female, who are white, who are employed, higher education, and higher income. So if we can also work to help facilitate as we're treating patients, help them with employment, maybe getting their education back on track, something to help with their whatever the life event, the precipitating events that may have occurred beforehand would also help with the response. Treatment resistance is defined as failure to respond to 2 separate trials of different antidepressants of an adequate dose and duration. After 2 trials, the possibility of responding to future trials does decline, and up to 46% of patients do not experience sufficient response. So what do you do with non-responders? So nearly 2/3 of all patients will fail to achieve remission with initial pharmacotherapy. Over 30% will have unsatisfactory response to 4 courses of antidepressants. And what are some possible reasons for that? Well, it may be comorbid disorders. There could be an inadequate dose or duration, so we didn't maximize the dose. We didn't treat long enough, so maybe we stopped it after 6 weeks or something, or after a couple months, and the patient regressed. It could be an incorrect diagnosis, so it's not actually major depressive disorder. Could be non-adherence, persistent adverse events, pharmacokinetic or pharmacodynamic factors like drug interactions, or unaddressed psychosocial stressors. So those precipitating events that may have led to the depression weren't addressed also. You want to switch medications if there's no improvement by 4 to 6 weeks. No study has demonstrated to benefit of switching to an antidepressant with the same or different mechanism of action. So what does that mean? You can, just because they fail one SSRI does not mean that you can't then switch to another SSRI. They may have benefit with that within the same class. You don't have to pick a different class of antidepressant if they fail one agent. I've seen a lot of patients, they'll basically go through all the SSRIs, then go through the SNRIs because they don't want to go to the TCAs or the MAOIs that we'll talk about in a minute because of their safety profile. And then they'll do that until something does benefit the patient. And you want to cross taper or titrate both medications over 2 weeks unless there's potential to not have to do that if they are in the same class of medications. You can augment if a patient has had some response, and you can do that with a second antidepressant, and or there's a few other options we'll talk about at the end of this lecture. So here are some options for psychotherapy. Some other options: vagus nerve stimulation, TMS, transcranial magnetic stimulation. I've seen a few more articles on that recently. That might be gaining some ground in patients. And the ones I've read are how the differences between young adults, older adults, and the elderly on kind of the level of stimulation they need. Again, we talked about initial choice. So when you choose, you want to take familial antidepressant response into account. We know there is a genetic part to depression, and usually that if somebody has had a first degree relative that responds to a medication, they will have a response also. You want to look at concurrent medical history, presenting symptoms, so fatigue or agitation, increased appetite, decreased appetite, and kind of match it up maybe with some side effects. If a patient has decreased appetite, they're just not hungry ever because of their depression, then you don't want to give them a medication that causes weight loss. If they can't go to sleep, they're up all night worrying, then you probably want to give them a medication that does cause somnolence. Potential drug interactions, adverse event profile, and cost. And again, failure to respond to one medication in a class does not mean they won't respond to one in the same class. So what are our options for antidepressants? We have, again, SSRIs, SNRIs, TCAs, MAOIs, and then some that are were just referred to as atypicals, where they're kind of in a class of their own. And they're listed there. We'll talk about them in just a minute. So SSRIs, so how do they work? So they selectively inhibit the serotonin reuptake pump. So when when the neuron releases serotonin into the synapse for it to act on the next neuron, the first neuron will reuptake that serotonin because it's going to save it to be used again. It doesn't want to have to make serotonin every time because that's just not efficient. So what we're doing is we are blocking that reuptake to leave serotonin in the synapse. So what happens is so we're going to initially increase serotonin in the synapse. Then, because of that serotonin increase, what that second bullet says is there is going to be a downregulation of serotonin autoreceptors, which will eventually cause an increased release of serotonin overall. So SSRIs, it's one of the reasons why it takes 6 to 8 weeks to reach full effect with these medications, is that we're not just increasing serotonin, we are also, because now we have more serotonin, we're essentially telling the neuron that to get rid of, we're overstimulating some of the receptors on the neuron, which overall in 6 to 8 weeks causes an overall increase in serotonin release in general. So you're going to have more activity of that serotonin, that's why it takes so long for these medications to become fully effective. These medications are safe in overdose, and they have very good tolerability, and they're all inexpensive. They're all available generic, and some pharmacies even have them for $4, $9, $15, whatever their list is at the time. Most of these are on there. So your examples are sertraline, fluvoxamine. That one is on there because it is an SSRI, but it is not indicated for depression. It is only used for obsessive compulsive disorder, but I put that on there for completeness. Paroxetine, fluoxetine, citalopram, and S-citalopram. So here's your typical dosing of these medications. You can see that they all have an initial dose, and then they have a maximum usual daily dose over here that you would want to target. And then if there is any renal or hepatic dose adjustments, they're listed over here. I will point out here on this slide that your renal and hepatic dosing, you can see that paroxetine has a maximum for both of them and has an adjustment, renal and hepatic, whereas the other ones, there's 2 that are hepatic and 2 that do not have any type of adjustment. So you do have options in patients who maybe have renal or hepatic disorders. Drug interactions, you're going to have some effect from 3A4 inhibitors, 2D6 inhibitors, which are the ones that I really keep in mind. They're going to inhibit the metabolism, and I'm more worried about paroxetine and fluoxetine right here. The sertraline, it's hard to get it to a high enough dose to make the 3A4 inhibitors that influential, but the 2D6 is the real big one. And then fluvoxamine, you see on here that it's kind of on each one of them. So just remember that fluvoxamine has a lot of drug interactions. You're also going to have NSAIDs, antiplatelets, and anticoagulants that have an increased risk of bleeding. That's due to the SSRI's effect on platelets. So it does not mean it's contraindicated. It just means there's an increased risk. It's a small risk, but you just want to warn the patients beforehand. And you have serotonergic agents, other serotonergic agents, which increase your risk for serotonin syndrome, which we're going to talk about at the end of this lecture. Class-wide side effects. These are, in general, most are going to be overall for the entire class. You're going to see one of the top ones is sexual dysfunction. It's not surprising. We know that increased serotonin, the serotonin aspect of it, can cause some sexual dysfunction. You can give cyproheptadine, to reverse it, or what I just recommend is just changing the medication. Drowsiness is common. You can see weight gain, insomnia, anxiety. But you can see most of these happen in about 10% of patients. And a lot of these may be based on, what were their symptoms of depression. If you couldn't sleep at all while you were depressed, you're probably going to report drowsiness with taking the medication, because you're now getting back to normal circadian rhythm. Weight gain. If you lost weight, then you're going to report that you've gained weight during the trial. You can see here you have drowsiness and insomnia. Well, it may have been the symptoms of that patient's depression may have played a role in that. And you can also experience increase in agitation or anxiety in the first 2 weeks. That is not uncommon with antidepressants, and a patient may need some kind of PRN medication to treat those. So the individual SSRIs, what makes them different? So fluoxetine is a very good antidepressant. What's its niche, or what makes it different? One is it has a long half-life. So it's 1 to 3 days, which means it has a long duration in the body. It's great for patients who have compliance issues. And that's just patients who, in a 7-day span, they may remember to take their medication 4 or 5 days. They just forget. They're not on a good rhythm. Maybe their shift changes and they work first, second, and third, and they can't find a good time to remember how to take it. It's a great medication for that. It's also good if you have a long half-life and a long duration in the body. If if a patient may decide, if you think you have a patient who may decide to stop taking their medication without letting you know, it has a much slower titration out of the body once you stop taking it. So you don't have to really taper the medication down. It self-tapers as the body metabolizes it. It is a significant inhibitor of 2D6, so you may want to watch it with antipsychotics, especially ones that can cause extrapyramidal side effects. It's a pregnancy category C, so it is a safe medication to give in pregnant patients, and it may be activating to some patients. So you may be able to use that in some patients who were, to give them a little bit of energy, to give them something to get off the couch, get out of bed, something like that. So it's really good for that long half-life, and it has a metabolite that has a really long half-life. And for patients who are have low energy, it's a really good medication for those patients. Paxil. Paxil is kind of like the opposite of Prozac, of fluoxetine. It has a very short half-life, so even missing 1 to 2 doses may cause withdrawal symptoms. It's also a significant inhibitor of cytochrome P450-2D6. It is a pregnancy category D. It is the only SSRI that is a pregnancy category D. Everything else is a pregnancy category C. It is more likely to cause sedation. Sorry about that. It is more likely to cause sedation and nausea when starting, and it has higher rates of weight gain and sexual dysfunction. I personally don't have a whole lot of patients who start out on Paxil because of those limitations. The bigger side effects, pregnancy category D, short half-life. Usually I highly recommend other SSRIs before Paxil, or even bupropion or mirtazapine. I'm not a big fan of Paxil. I just think there's better options out there. Zoloft, sertraline doesn't have any significant drug interactions. It's also a pregnancy category C. It may be better absorbed when taken with food, so I recommend taking it with breakfast or just any meal. And it's more likely to cause diarrhea in the first week or 2 of taking the medication. So again, I recommend taking it with food so it doesn't cause as much upset stomach. Citalopram, another good medication. No significant drug interactions, pregnancy category C, may cause less sexual dysfunction than other SSRIs, but it also may cause arrhythmias at higher doses. So back in, I want to say it's 2011, 2010, they decreased the maximum dose from 60 milligrams a day to 40 milligrams a day, and I would want to avoid this in patients who have an arrhythmia or cardiac abnormalities. Escitalopram, again, it is just the I don't want to get too into the chemistry of these, but it is basically just the S enantiomer of citalopram. So it is. God, how do I not bore y'all with this? If you remember back to chemistry, there's basically two mirror images of a chemical structure. They have taken the S enantiomer out, left the R, and it is not more effective. It isn't cleaner. It's just another option. It still has most of the same. It still has no drug interactions. Same pregnancy category. Still may cause arrhythmias, and you can see that it's 10 milligrams of escitalopram equals 40 of Celexa. So you do have room to go up on that, up to 20 milligrams, where you don't on Celexa. So it's slightly more potent, but it's not more effective overall. Again, fluvoxamine or Luvox is only approved for obsessive compulsive disorder. It is not used for, it can be effective for depression or anxiety, but really only if patients also have comorbid obsessive compulsive disorder. You don't see this used off-label for only major depressive disorder. And it has a lot of drug interactions, especially with cytochrome P451A2. So what are you going to normally see with a patient? The ones in red are the biggest things to monitor for a patient and give them a heads up for. So GI disturbances within the few weeks, just the nausea, vomiting, diarrhea, that typical thing that patients complain about when starting a medication. Anxiety and insomnia should resolve around the first 2 weeks if it causes it. Sexual dysfunction is a common complaint for patients. It will not resolve usually. They'll have to have some kind of treatment for it or switch medications. And then the ones below that are pretty low risk. So they can cause hyponatremia, not usually just by themselves. It's usually in combination with another medication. Or if you have a patient who has low sodium and is on an SSRI, you may want to be able to switch them to something else. But we don't commonly, check electrolytes on a routine basis, just watching for that hyponatremia. So, discontinuation syndrome. Abrupt discontinuation of an SSRI can cause anxiety, headache, insomnia, tearfulness, irritable mood, paresthesia, dizziness, and vivid dreams. And it usually happens 12 to 48 hours after discontinuation. And Paxil is by far the worst offender of that. So if you need to, even if somebody's on Paxil and they're like, I'm going to stop taking it, if we can put them on a different SSRI for a few days, then maybe Prozac for a few days to let it slowly taper off, we can try to avoid that. But definitely don't let your patients try not to let your patients just stop an SSRI altogether, even if it's not being effective. They're still going to have those symptoms. So, serotonin norepinephrine reuptake inhibitors. They block the reuptake of serotonin and norepinephrine in the same way that the SSRIs do serotonin. So, it stands to reason that they're basically going to have the side effects and the same profile of your SSRIs, but add in the norepinephrine. The examples are duloxetine, venlafaxine, and desvenlafaxine that are approved for major depressive disorders. Studies have shown it's very inconclusive to show the studies that show that they're better than SSRIs. They're not. They're just as effective, but they're another option for patients. They have the same adverse effects as SSRIs, but they do have some activation, some dose-related blood pressure increase because of the norepinephrine. They can have decreased appetite and insomnia and sweating. And overdose has the potential to cause hypertension and cardiac arrhythmias, again, because of that norepinephrine component. So here's dosing. Again, you can see I've got the initial dosing, the usual daily dose, the maximum, and then any adjustments that may need to be made. I have the levomanaceprin down here at the bottom. That is used for fibromyalgia, I believe, but it is not approved for major depressive disorder. Again, it's just for completeness. So how do you know? How do you tell these medications apart? What separates them from other SSRIs or SNRIs? Um, Duloxetine or Cymbalta is a substrate of 2D6 and 1A2, so you want to watch for drug interactions. It is contraindicated in uncontrolled narrow angle glaucoma. You want to use it cautiously in liver disease. I would tend to go with something else unless the patient, just has to have this medication. They were already on it, developed liver disease, but it's very effective. You just want to dose adjust. The blood pressure increase is negligible, especially compared to venlafaxine that we're going to talk about next. And it can also be used for fibromyalgia, chronic pain, and neuropathy. So there you've seen two of those bullets. If your patient has uncontrolled narrow angle glaucoma, you're not going to use it. If a patient has fibromyalgia, chronic pain, and neuropathy, this is a good one to start with instead of maybe another SSRI or bupropion or mirtazapine. Venlafaxine or Effexor, you can titrate this dose up very quickly, and you must have good liver function to convert it to its active metabolite. And it has a dose-dependent increase in blood pressure. So that's one you're going to want to watch if a patient has uncontrolled hypertension. Desvenlafaxine or Pristiq, it is the active metabolite of venlafaxine. I like this bullet right after this. It provides no benefit over venlafaxine. It's more expensive. It's not any more effective. As long as you have good liver function to metabolize the Effexor, there's no difference in Pristiq or the desvenlafaxine and venlafaxine. It's a weak inhibitor of 2D6. Dose should be increased slowly. It may cause a small weight reduction, but I don't think that is. I think that was statistically significant, but not clinically significant when we really look at patients. And it is expensive because it is still name brand only. Those are our three SNRIs. We're now going to jump to what's usually called the atypicals. So these are also still first line options for depression. Bupropion I've seen used quite a bit because it has a unique mechanism of action. So it blocks the reuptake of both norepinephrine and dopamine, but not serotonin. So this is a completely non-serotonergic antidepressant. It is a potent 2D6 inhibitor. It can increase the patient's energy level. So if we have a patient who is lethargic, who has gained a lot of weight, who doesn't have a lot of joy in their normal daily activities, this is a good option for these patients to kind of give them a little get up and go. As a lowest incidence of sexual dysfunction because of that lack of serotonergic activity. You can also use it for tobacco dependence. So if you have somebody who may want to stop smoking at the same time, or at least decrease the amount of smoking. And it may cause weight loss. So, this would be a good option for patients who have gained weight and who have low energy levels because of their depression. I know that I knew several people who, I went to college with who, a couple years after college reached out and were getting recommendations, and they had a really good effect on Wellbutrin because they had that kind of that lethargic, their symptoms of depression. They were lethargic, they ate a lot, they didn't have any motivation, any energy, and this worked really well for them. Adverse effects. You can see these adverse effects. Usually it's just the nausea and vomiting and maybe insomnia if it's taken too late in the day, but you can see these other ones. It does decrease your seizure threshold, so you don't want to use it in patients who already have some type of seizure disorder. And it's contraindicated in eating disorders like bulimia and anorexia because it can worsen those eating disorders. We saw that it can increase your energy level and may cause weight loss, so we don't want to worsen anorexia or bulimia. And it may cause agitation or activation like some of our other antidepressants. So what are the advantages of it? It's novel pharmacology, kind of like a stimulant-like effect with norepinephrine and dopamine. It can be a good augmentation strategy or monotherapy. So you may have them on just Wellbutrin or give them Wellbutrin and an SSRI. So now we're blocking the reuptake of all three neurotransmitters. And it has a lack of sexual dysfunction, sedation, and weight gain that your patients are likely to complain about if they have. Disadvantages: it can be stimulating if that's not a good effect for your patient. It does have drug interactions to keep in mind. It has a modest efficacy versus other agents, and the risk of hypertension and seizures with a patient who already has one of those disorders. Now, basically the opposite of bupropion is mirtazapine. It enhances serotonin's effects at the 5-HT2 and 5-HT3 receptor, and it enhances norepinephrine. It has lower anxiety and GI effects. It does have a low incidence of sexual dysfunction, but it causes weight gain and sedation, like the opposite of Wellbutrin, which causes weight loss and an increase in energy. So this might be a good option for your patient if your patient stays up all night worrying. They don't eat because their stomach's upset. It's clenched because they're so nervous all the time. They're anxious, and that they need something that's going to help them sleep and is going to help them gain some weight. It's also interesting that this bottom bullet, that you have less weight gain at larger doses. It's not a dose-dependent increase in weight. So, you can quickly get them up to the 45 milligram max, and not have to worry about that the weight gain is going to just keep going, like you would see maybe like antipsychotics, where they're going to get to like 100 pounds of weight gain. Usually they'll get back to just their baseline, or a small increase, and then kind of maintain after that. So mirtazapine is everything we've mentioned beforehand are good antidepressants. They're all first line. They're all fairly well tolerable. And if your patient does complain about a side effect, you have lots of other options to switch to. Then come trazodone and nifazodone. So they inhibit serotonin reuptake. They are not SSRIs, but they are going to have some more side effects and precautions that kind of push them to second or third line options. So adverse effects: orthostatic hypotension, sedation, cognitive slowing, and dizziness. And you have precautions with them. So trazodone at an effective dose has a risk of priapism, and nifazodone has a risk of liver toxicity. So I don't see a whole lot of nifazodone used anymore. I do see some trazodone, but it's basically using that sedation at a very, very low dose for sleep for our patients who have depression. And whether that's a good idea or not, it happens. And at that dose, there's such a minimal risk of any of the other side effects that it's not really that big of a problem. So here you can see it's just another chart that can help discern between these different categories. Tricyclic antidepressants, or TCAs, examples are amitriptyline and nortriptyline. They inhibit the reuptake of norepinephrine and serotonin. And you can see that their adverse effects, that list is growing a little bit, which is why it's a second or third line medication. You can have dry mouth, constipation, blurred vision, and urinary retention. So anticholinergic effects. Remember, anticholinergic from pharmacotherapy: dry mouth, constipation, can't see, can't pee, can't spit, so we're going to have those side effects. Dizziness, tachycardia, memory impairment, weight gain, sexual dysfunction, and delirium at high doses. So they're not quite as safe in overdose, not quite as tolerable, but which is why they're not first line options. Here we have the recommended initial doses and the dosage range for patients. They're not used for depression as much anymore because of the better tolerated options, and they're more lethal than SSRIs in overdose. Precautions are orthostatic hypotension at high doses, and they can cause heart blocks and arrhythmias, especially in overdose, and that is just by themselves. That's not just in combination with other medications that can cause it. And you want to taper them over several days to prevent dizziness, nausea, diarrhea, insomnia, and restlessness. So taper them over at least 2 weeks if possible. In toxicity, you're going to see a prolonged QT interval, arrhythmias, heart blocks, seizures, serotonin syndrome, and anticholinergic delirium. And precautions, you want to avoid them in patients who have recent MI, conduction abnormalities, tachycardia, history of prolonged QT interval, and narrow angle glaucoma. You can see here there's drug interactions that we want to watch out for. Pretty similar to what we've talked about before. You're going to monitor TCAs, you can do plasma levels. You don't monitor them like you would lithium, looking for a goal and keeping them in that range. But you can monitor TCA limits or levels, blood pressure and heart rate, weight, anticholinergic effects, QT interval, sexual dysfunction, and then you want to monitor for discontinuation syndrome. Again, you could do those, every 6 months when they come in for appointments, or quarterly if they're already coming in. But I wouldn't probably do it any more frequently than that. Again, here's some TCA overdose symptoms. How your symptoms of overdose you're going to see. And then we get to MAOIs, or monoamine oxidase inhibitors. So these are not used anymore either, because of better tolerated medications, and they're lethal in overdose. So you see phenelzine, and then selegiline. It's all available in tablets, capsules, and patches. I haven't seen these used for depression in a long time. Now it's for other disorders. It increases overall. It causes an increase in the concentration of norepinephrine, serotonin, and dopamine. It is an irreversible inhibition of that enzyme, which those enzymes break down those three neurotransmitters. It also has some histaminergic alpha-1 blockade and muscarinic affinity. So side effects. You can see this list is growing longer too, just like our TCAs. Weight gain, drowsiness, orthostatic hypotension, hepatotoxicity. Where some more severe things are popping up on here also. You can have serotonin syndrome and hypertensive crisis with these medications. Serotonin syndrome, you cannot use other antidepressants with MAOIs because of that increased risk. And you actually have to separate them out by 2 weeks because of the risk of serotonin syndrome. Your contraindications: concurrent use with antidepressants, meperidine, sympathomimetics, or tyramine-containing foods, or uncontrolled hypertension because of that hypertensive crisis risk. You want to monitor blood pressure, heart rate, weight gain, additional agents with serotonergic effects, not just antidepressants, but other medications like tramadol, or your serotonin agonist for nausea, Zofran and those kind of things. Your triptans for migraines, those are going to have effects also. Tyramine-containing foods, so like aged foods, aged cheeses and meats and things like that. Wine, they're gonna increase the risk of hypertensive crisis, and you do not want to discontinue these abruptly, or else you're going to get rebound effects of those receptors we've been blocking. So again, you can see here a long list of drug interactions. SSRIs, a minimum of 2 weeks between use, and you have to wait at least 5 weeks with fluoxetine because it has that long half-life. TCAs, meperidine, triptans, tramadol, levodopa, psychostimulants for ADHD, sympathomimetics, dextromethorphan for cough, and other antidepressants. So they're not clean drugs by any means. The reason we have such a strict drug-food interactions is because MAO is responsible for breaking down of digested tyramine in the gut. MAOIs prevent that breakdown, which causes an absorption of tyramine, which runs the risk of hypertensive crisis. So patients must adhere to a low tyramine diet, which means you have to limit things like dry and aged smoked fermented fish, meat and poultry, broad bean pods, aged cheeses, tap or non-pasteurized beers, sauerkraut, and soy products. So you have a few things that are like this is allowed, and then this side is foods to avoid, because you're risking elevated diastolic blood pressure, headache, tachycardia, arrhythmias, and stroke if it's not kept low. So some of the newer medications for depression, Vibrad or vilazodone and vortioxetine, they are essentially SSRIs with some additional effect, depending on what different receptors. The main things to get for them are they are other options. They have the same efficacy as SSRIs, and vilazodone has an increased risk of diarrhea and nausea over other depressants, and vortioxetine has an increased risk of nausea. And they're both expensive. So the kind of the benefits that we wanted to see with these other receptors also being hit, which might make them more tolerable or more effective, we really didn't see. So they're just other options to use, and I would say they're second line because of the cost, and insurance companies may or may not cover them. So they're going to be a lot more expensive with not a lot of benefit for our patients. Augmentation strategies for patients. So you can use lithium, which is a good response, which is a gold standard augmentation agent. You'll see response within 72 hours, possibly. You can give thyroid hormone or Synthroid. You obviously want to monitor your thyroid function test because you don't want to have hyperthyroidism. Ketamine again is iffy because you're having to do an IV infusion, but there's benefit. There's kind of a growing niche for ketamine right now, or S-ketamine. But again, you should have a little hesitation when using that. You wouldn't want to use that for every patient because of the other effects it can have. Second generation antipsychotics we know that have antidepressant effects. Buspirone and stimulants for certain patients to augment for certain side effects. St. John's wort, I will say that St. John's wort is an herbal medication. It is not regulated, so the options over the counter are all widely variable in potencies. The efficacy is very mixed, and it has very significant drug interactions. So I do not recommend St. John's wort to other patients or to patients because of those drug interactions. And you can, I definitely don't recommend using St. John's wort and antidepressants together because of that risk of serotonin syndrome. A few, just quickly, some of the newer medications that have come out, just to give you an overview. The brexanolone is an injection for postpartum depression. It was approved in 2019. It's an analog of a human hormone that modulates GABA receptors. The downside of it is it's a continuous intravenous infusion over 2.5 days. So it's treating a thing that needs to be treated, but it does take 2.5 days for treatment. It has to be administered by a healthcare provider and a certified healthcare facility under close monitoring. And sleepiness, dry mouth, loss of consciousness, and flushing were the most common adverse effects. Clinical improvement was seen within 24 to 60 hours of starting the infusion, and the duration of effect was demonstrated up to 30 days post-infusion. So, because of the concerns about serious risk, including excessive sedation or loss of consciousness during administration, brexanolone has been approved with a REMS program. So you have to sign up. Everybody has to be certified, monitored in a certain way. You have to go through this program to administer and to get this medication. And the cost is about $34,000 per course of treatment. So I'm not sure if any of the med-surg hospitals are using this. This isn't an option for our hospital because we don't do continuous infusions. But it is effective, and I've heard that they are coming out with they're working hard to come out with a tablet version of this that doesn't require the IV continuous IV infusion. So keep an eye out for that. You should see that in the news soon-ish, at least starting trials. S-ketamine or Spravato is an intranasal spray for treatment-resistant depression. It's in conjunction with an oral antidepressant for treatment-resistant depression in adults. It's also been approved for decreasing suicidal ideation with a pretty quick effect. It facilitates the release of glutamate, leading to AMPA receptor activation. So it's an NMDA receptor antagonist. So this activation or release of glutamate is the first antidepressant we've seen that has an effect on something other than norepinephrine, dopamine, and serotonin. So we may see more and more glutamate modulation coming in the next couple years. So you do have an induction phase. So there's a set schedule on how to give this with You start off and you can give it twice a week, and then maintenance phase would be once weekly, and it has a set schedule to be given. The onset of action, you're going to see clinical improvement of depressive symptoms within 24 hours of the first dose, and the effects can last several days. There are some adverse reactions. There's some patients will complain of dissociation, but they return to normal within 90 minutes. You're going to see sedation, increase in blood pressure, and then some other ones that are at a lower percentage. But you can see here that all these side effects return to normal within 90 minutes. You do have to certify within a REMS program, and patients who get this, even though it's an intranasal spray, they have to be watched at a healthcare facility for at least 2 hours after administration because of that dissociation side effect. And I highly recommend not letting them drive themselves to and from the appointment. They should really have somebody else drive in case that side effect happens while they're driving home. For blood pressure, you want to assess the blood pressure prior to dosing and consider delaying therapy if it's over 140 over 90. Average increase usually happens within about 40 minutes and then tails off after about 90. This is the nasal spray in general. If you do use this, you can actually reach out to your drug reps. They'll send you not samples. There's no drug in it, but it's a practice one to show how it clicks, and there's 2 doses in each one, and how it uses. And these little green dots will turn red once the dose has been used, and then the tester you can actually reset, and kind of that way your whoever's giving it can have good practice on what it should be like to give it. So choosing the right medication, we've talked about this before. I'm not going to go through this list, but here's some charts that may help push you towards one or the other. So citalopram or escitalopram if they have a lot of other drugs and you want to lower the risk of drug interactions. Fluoxetine for compliance issues. Mirtazapine for insomnia. Bupropion for lack of energy, or if they want to avoid sexual dysfunction or they have tobacco dependence. Duloxetine if the patient also has pain or fibromyalgia, and SSRIs if the patient has a high risk for overdose. Here's a list of contraindications we talked about earlier with each individual medication, but you can see how each one has a patient population you would want to avoid its use. Quickly before we're done, serotonin syndrome. Serotonin syndrome is a potentially life-threatening condition associated with increased serotonergic activity. Mental status changes include anxiety, agitated delirium, restlessness, and disorientation. It also has autonomic manifestations, diaphoresis, tachycardia, hyperthermia, hypertension, vomiting, and diarrhea. And it can manifest as tremor, muscle rigidity, myoclonus, hyperreflexia, and bilateral Babinski signs. So, looking at all of those, most of the time you're going to see serotonin syndrome, or you may hear it talked about like, oh, it's a risk, but it doesn't actually happen. It's just one of those things we have to tell people about. And usually that's true. Where the real risk for serotonin comes is really when you have multiple medications that have serotonergic activity. So I actually know somebody who was sent to the hospital in Columbia, South Carolina, for what everyone thought was a heart attack. She was having palpitations, tachycardia, she was sweating, she was having what she said was like muscle pain on the left side. They knew she was having a heart attack, but all her tests came back negative, and it wasn't resolving. And it wasn't until they did her admission medication reconciliation when they realized that she was not only on 2 antidepressants, but also on other serotonergic medications. So she was on 2 antidepressants, tramadol, triptans for migraines, and I always forget what the 5th one was. But that combination led to an increased serotonergic activity that she just could not tolerate. So luckily they were able to change her medications. And you can see here, serotonin syndrome is potentially lethal, and it's usually the concurrent use of medications with serotonergic properties. So we have obviously listed our antidepressants first, but you can also have use with your triptans for migraines, carbamazepine, cyclobenzaprine, the muscle relaxer, Flexeril, dextromethorphan for cough, lithium, metoclopramide, St. John's wort, tramadol, buspirone, and linezolid, which is an antibiotic, but also acts as an MAOI in the body. So you can have a combination of these medications, some of them even short term. You get a week supply of Flexeril because you pulled a muscle in your back, or linezolid because you have an infection, and linezolid treats MRSA and is available in a tablet, so we'll give you that one as opposed to needing to give you an injection. So you can get put on one of these short term, and that is what triggers what pushes what tips the scale to lead to serotonin syndrome. So, what are the symptoms, or what are you most likely going to see with serotonin syndrome? There's an acronym called HARMD. So hyperthermia, autonomic instability, rigidity, myoclonus, encephalopathy, and diaphoresis. And how are you going to treat it? Well, you're going to discontinue the serotonergic medications, the ones that you can, and you're going to provide supportive care. For most patients, that's going to be enough. If supportive care fails, you're going to give cyproheptadine, which will act as a serotonin antagonist. You're also symptoms should usually resolve within 24 hours of treatment initiation, and then you're going to find other treatment options. So, maybe if they need to be on the antidepressants, maybe switch them to bupropion and one serotonergic antidepressant. Switch the tramadol to something else. Give them a different option for the triptans for migraines. You could use one of the new classes that came out for migraines. So something like that. You're going to get less overall serotonergic activity. So again, quickly going over response to medications, you'll see some symptom improvement over 1 to 2 weeks. Full remission may not take until 8 to 12 weeks. And patients who don't respond within 4 to 6 weeks at all, you can go ahead and switch them to a different medication. Duration, most patients are 1 to 3 years. If this is multiple episodes, then they may remain on it indefinitely, especially if they're younger than 40 with 2 or more episodes, or any person who's had 3 or more prior episodes. They're indicated for lifelong treatment. So again, that's the same slide. Here's special populations. If you have patients who are in these, pregnancy, untreated always has more adverse effects than treated patients. I recommend the SSRIs or SNRIs that are not paroxetine. Pediatrics, some do have FDA approval, but you can use all of them. You just want to watch that increased risk of suicidality. And the elderly, a lot of times major depressive disorder is overlooked in the elderly, and usually they get a good effect from a lower dose than that you want to try to stick with monotherapy in the lowest dose possible to decrease any side effects. All right, so that is antidepressants. So if you have any questions, feel free to let me know, and either shoot me a message through Canvas, an email, or post something on that discussion page that we have. And next up will be anxiety disorders.